Hello everybody, welcome. Today I'll discuss about development of the abdominal organs. Okay, so first of all, you have to know that the abdominal organs are derived from endoderm, especially the abdominal organs which are gut and gut related glands, and those gut and gut related glands actually develop from something called a primitive gut tube, and this primitive gut tube actually develops from yolk sac. Okay, so here you can see a picture which is a cross section of the fetus at about 2 or 3 weeks, and above you can see the amniotic cavity, and then you can see the three germ layers. So you have the ectoderm, mesoderm and endoderm, and this endoderm is actually derived from yolk sac. Yolk sac will actually fold and give rise to the endoderm, which will ultimately form the primitive gut tube, and this happens by the pressure from the lateral body fold. So here you can see the lateral body fold, which will actually press on the yolk sac and will ultimately form the gut tube. So it's in the formation of in the process of formation of the gut tube, and still the yolk sac is connected to the future gut tube by something called a Vitelline duct. Okay, so here you have the fully formed gut tube, which is actually surrounded by a cavity which is called coelomic cavity, and later it will be called a peritoneal cavity. So this is a very important slide which shows you the different parts or segments of the gut tube. So you have 3 segments: the foregut, the midgut and the hindgut. And the foregut not only develops the gut structure, but also note that the foregut also develops lung bud and ultimately the mature lung. And also note that the midgut is actually still connected with the yolk sac by the Vitelline duct. And all of those gut tube, especially the foregut and midgut, undergoes some degree of rotation, and foregut undergoes a 90-degree rotation and the midgut undergoes as 270-degree rotations. Okay, so this shows the important landmarks of development. So the divisions of the foregut, midgut and hindgut actually is very specific. So foregut is from esophagus up to something called ligament of Treitz, which is present in the second part of the duodenum, and after ligament of Treitz you start with midgut, and which is up to the proximal 2/3 of the transverse colon. Okay, so you will have development of third and fourth part of duodenum, ileum, jejunum, ileum, and then cecum, vermiform appendix, ascending colon, and then proximal 2/3 of transverse colon. And hindgut is the distal 1/3 of transverse colon and up to the pectinate line. So you'll have the distal 1/3 of transverse colon with descending colon, and sigmoid colon and rectum. So this is very important to remember. And also those gut structure, each of them has a specific artery. For foregut you have the celiac trunk, for midgut you have the superior mesenteric artery, and for hindgut you have the inferior mesenteric artery. And the foregut and midgut, both of them gets parasympathetic supply from vagus nerve, and both of them get sympathetic supply from the spinal cord segment, thoracic 5 segment of the spinal cord up to the thoracic 12th segment of the spinal cord, both of them. But about the hindgut, it gets the parasympathetic from pelvic splanchnic nerve and sympathetic from first and second spinal cord segment of the lumbar region, so L1 and L2. Here you can see the development of the stomach. So stomach is a foregut derivative, and as foregut goes 90-degree rotation, stomach will also go at 90-degree rotation. But first, stomach actually develops as a fusiform dilatation of the proximal part of the foregut, which undergoes rotation, and the part of the stomach which actually was a posterior part, this actually becomes the left part, and anterior part becomes the right part, and the posterior part actually grows faster, and which ultimately gives rise to something called greater curvature, and anterior part grows slower, and which will ultimately be called a lesser curvature. And as you can know, the vagus has 2 trunks, the right and left vagus, but due to this rotation the left vagus becomes the anterior vagal trunk and the right vagus becomes the posterior vagal trunk. And in below you can see there the stomach also undergoes something called the anterior posterior axis rotation, and that's why the proximal part becomes the left, proximal part goes to the left side and the distal part goes to the right side. Okay, and the stomach starts developing into a fusiform dilatation at about 4 weeks. Actually, all of your major organs start to develop at about 3 or 4 weeks and complete or almost complete the development during up to 8 or 10th week. So 3rd week to 8th week is the weeks of organogenesis. Very important to remember. So here you have another derivative of the foregut, which is the liver. Okay, so the liver actually develops from something called a liver bud, and here you can see a cross section. In the 1A, you can see a cross section of the fetus at about 2nd or 3rd week, and this fetus has foregut in the center, and the foregut is actually connected to the ventral body wall and dorsal body wall by something called a mesentery. So in the ventral portion you will have the ventral embryonic mesentery, and in the dorsal portion you will have the connection by dorsal embryonic mesentery. And the liver bud is actually a structure that invaginizes into the ventral embryonic mesentery. So here you can see the liver bud, and ultimately it will develop into liver and the biliary system. So not only liver but also gallbladder, hepatic ducts and common bile ducts, all of them develops from the liver bud. And also you can note that the portion of the ventral embryonic mesentery that connects the foregut with liver will be later called the lesser omentum. Very important to know. And the portion of the ventral embryonic mesentery that connects the liver with the anterior abdominal wall will be called a falciform ligament. Also very important to know. Please note those. Here you can see the development of pancreas, but unlike liver, the pancreas actually develops from 2 buds. So it has something called a dorsal pancreatic bud and a ventral pancreatic bud. So the ventral pancreatic bud invaginates into the ventral embryonic mesentery, so this is the ventral portion, and the dorsal pancreatic bud invaginates into the dorsal embryonic mesentery. But ultimately both of those will fuse and form the adult pancreas. So here you can see the dorsal pancreas here and ventral pancreas here. It developed from the dorsal pancreatic bud, developed from the ventral pancreatic bud, and both of them will ultimately fuse. And you can remember the derivative of the both of them. The ventral pancreas or ventral pancreatic bud actually gives rise to head and uncinate process. The dorsal pancreatic bud gives rise to neck, body and tail. And also note that the main pancreatic duct is actually a derivative from the dorsal pancreatic bud, and the accessory pancreatic duct is a derivative from ventral pancreatic bud. And also you can remember that main pancreatic duct opens into the second part of duodenum in something called a major duodenal papilla, and the accessory pancreatic duct opens into the second part of the duodenum through something called a minor duodenal papilla. And whenever there is a problem of fusion between ventral pancreas and dorsal pancreas, there will be something called an annular pancreas. So in case of annular pancreas, the ventral pancreas is connected to the dorsal pancreas both anteriorly and posteriorly. So it actually hangs or strangulates the second part of duodenum. So there is obstruction of the second part of duodenum, and there will be formation of polyhydramnios in case of annular pancreas. Okay, and also in the fetal or neonatal life, it can present as obstruction, gut obstruction. Here you can see the development of the spleen. So remember that spleen is not a derivative of the gut, it's a mesenchymal tissue, mesenchymal derivative, but still it develops in the dorsal embryonic mesentery. Here you can see, and the spleen is connected with the stomach or with the division of the foregut with something called a gastrosplenic ligament, and it's connected with the kidney here. Those are the kidneys, 2 kidneys, 1 kidney here and 1 kidney here, by something called a splenorenal ligament. So here you can see the rotation of the foregut. So foregut undergoes a 90-degree rotation. So this is the primitive section of the foregut, where you can see the foregut
Here is the lesser omentum, which is also the connecting portion between foregut and the liver. The liver is can be seen here, but here you can see the spleen. This is a gastrosplenic ligament, and this foregut will actually undergo a 90-degree rotation. So the anterior portion will become the right portion, and the posterior portion will become the left portion. So the lesser omentum will actually go to the right side. So as you can remember from the adult anatomy, that liver is actually present in your right side of the body, but it actually developed in the front side of the body. But for the 90-degree rotation of the foregut, it actually taken its place to the right side of the body. And spleen, it actually developed in the dorsal embryonic mesentery, so it was in the posterior to the stomach. But for this rotation, spleen actually comes to the left side of the stomach. And also you have you have division of the peritoneal sac also. The portion of the peritoneal sac which was the right part actually becomes the posterior part, now which will be called a lesser sac. And the portion of the peritoneum which was the left part of the peritoneum or left part of the peritoneal sac now will be called a greater sac. And the lesser sac and greater sac are connected by a foramen which is called epiploic foramen, which will be important later on. So remember that lesser sac is behind the foregut and the greater sac is in front of the foregut. Lesser sac behind and greater sac in front. Very important to remember. And as you can see, the midgut also undergoes rotation, which is a 270-degree rotation, a bit complex, but this rotation actually goes into some stages. There is something called a first stage and a second stage and a third stage. But after this rotation, the midgut derivatives actually gets their position. So here you can see the ileum and jejunum here, jejunum and ileum here, appendix, the cecum, the ascending colon, the transverse colon. So all of this positioning of the organs occurs due to a 270-degree rotation of the midgut. Here you can see different parts of the peritoneum. So as you can see, this is the gut tube surrounded by peritoneum. The part of peritoneum that surrounds the gut tube will be called a visceral peritoneum because it is surrounding the viscerus. And the part of the gut tube that actually covers or invades the body wall, parietal body wall, will be called a parietal peritoneum. And the connection between parietal peritoneum and visceral peritoneum will be called a mesentery. So here you can see only the dorsal mesentery because most of the ventral mesentery actually ultimately will be degenerated or atrophied. So here is something called secondary retroperitonealization. So most of your GI tract organs actually has peritoneum, but some of those organs actually they actually go to the posterior region, and their mesentery and the visceral peritoneum actually gets fused with the parietal peritoneum. So they get peritoneum only on the one side, and the other part they don't have any peritoneum. So they get something called a secondary retroperitonealization. So here is a slide to show you what are the structures which are primarily retroperitoneal and what are the structures which are secondary retroperitoneal. So primary retroperitoneal structures actually never had a mesentery. They were always behind the peritoneum. And from the gut structure, which is lower rectum and anal canal, they never had a mesentery. Other organs, which are kidney, ureter, and adrenal gland, never had a mesentery. And vessels like abdominal aorta and inferior vena cava never had a mesentery. And some parts of the GI tract which had mesentery at some part of their life or development, but later it lost mesentery due to the fusion of the mesentery with the parietal peritoneum. So the second and third part of the duodenum, head, neck, and body of the pancreas, ascending and descending colon, and upper rectum. All of those are secondary retroperitoneal structure. So this slide is very important for you to remember, very important. It's something a bit of cramming, but you can also remember them from seeing some pictures. So here we discuss about some congenital defects that are associated with development of the GI tract, and the first one is infantile hypertrophic pyloric stenosis. So as you can see, it occurs in infants, most commonly in firstborn male. Hypertrophy of pyloric sphincter occurs, and if there is hypertrophy of pyloric sphincter, especially hypertrophy of pyloric muscularis externa, which is also called the pyloric sphincter, there will be polyhydramnios, because the baby will be unable to move past the amniotic fluid through its gut because there is obstruction. And also after delivery, after eating breast milk, after feeding with breast milk, the baby will have projectile non-bilious vomiting. Okay, non-bilious because for the bile to come to the stomach, it has to come through the pyloric sphincter. As the pyloric sphincter is closed, there will be a non-bilious vomiting, and this hypertrophy can actually give rise to an olive shaped mass in the right costal margin. And to treat that, you have to do something called a pyloromyotomy. And here you can see an ultrasonograph picture where this is the pyloric sphincter, and in between this is the pyloric canal. So you can see the pyloric sphincter is hugely enlarged, so there is hypertrophy of the pyloric sphincter actually, which compresses on the pyloric canal, so the pyloric canal becomes a slit like opening. Okay, that's why there is obstruction. Omphalocele is another congenital anomaly which occurs due to a derangement of the development of the abdominal structure, where actually the midgut loops fail to return to the abdominal cavity. As you can remember, at about 6 to 10 weeks, the parts of the midgut are actually situated outside the abdomen, and then they come back to the abdomen. So if there is any problem of coming back, returning, there will be something called omphalocele. But this omphalocele occurs or remains in the umbilical stalk, and it will be covered by a shiny sac of amnion. Very important to remember. Okay, so here you can see that the baby is having something outside of the abdomen, some organs, abdominal organs such as small intestine may be outside of the abdomen, but it is covered by a shiny sac of abdomen, and these structures actually protrude from the abdomen through the umbilical ring. Very important to note every point. So it has membrane, it comes out through the umbilicus. Very important to know. So look at the membranes, shiny membranes, which are amniotic membranes. So another condition, which is gastroschisis. In this case, the viscera of the abdomen is herniated through body wall and usually to the right of the umbilicus, most commonly due to two defects. One is defect in the closure of the lateral body folds, and another is weakness of the anterior wall of the abdomen at the site of right umbilical vein resorption. And note that the important differences between gastroschisis and omphalocele is that gastroschisis, in case of gastroschisis, the viscera do not protrude to the umbilical ring, and also it is not enclosed in a sac of amnion. So those two are the most important differences. So here you can see that there is a part of the gut, most probably small gut, is actually outside of the abdomen, and which is actually in the right to the umbilical cord or umbilical stalk. So the viscera did not protrude from the abdomen through umbilical stalk, and also the viscera does not have any membranes. So those two are the most important differences that you have to remember. There is another congenital anomaly, which is Meekel diverticulum, and as you can remember from your previous slides, that Vitelline duct actually connects the midgut with the yolk sac for a certain period of time, and then it undergoes degeneration. If this degeneration is incomplete, it will lead to some problems, and one of those is Meekel diverticulum. Meekel diverticulum is a blind pouch on the antimesenteric border of the ileum, and sometimes it may contain ectopic gastric, pancreatic or endometrial tissue. So it can have gastric ulcer, it can have pancreatitis, it can have endometrial bleeding into there. So there is something called a rule of 2. It's about 2 feet from the ileocecal junction, 2 inches long, and most of 2% of the population have it. So here I have shown you some Vitelline duct anomalies. All of them occurs due to incomplete closure of the Vitelline duct. So if the Vitelline duct is not closure completely, totally open, the gut tube, so here is the gut tube and here is the body wall and here is the Vitelline duct. So Vitelline duct will actually act as a communication between the gut tube and the anterior abdominal wall, and at birth it will present as passage of meconium from the gut tube to the abdominal wall, okay, especially if the baby cries. And if there is closure of the Vitelline duct in the portion which connects it with the body wall, and there will be formation of a blind pouch which is actually in the antimesenteric border, especially in the ileum, which will be called a Meekel diverticulum. And if there is incomplete closure of the Vitelline duct in the part of the body wall, it will lead to something called a Vitelline sinus. And if there is closure of the Vitelline duct from two sides, from the body wall side and from the intestine side, but if the middle portion is not degenerated, it will be formed as a Vitelline duct cyst, also called an anterocyst. And I have already mentioned that midgut goes at 270-degree rotation, and if this rotation is abnormal, there will be abnormal positioning of the abdominal viscera, which ultimately can lead to twisting of the abdominal organs, which is also known as volvulus. So the neonate will develop features of intestinal obstruction. So here we can see a volvulus is developing here. So here is a volvulus, and the proximal portion of the bowel is hugely distended, as the contents of the bowel cannot pass through the segment which is developing a volvulus. Hirschsprung disease is another congenital malformation of development of GI tract, and as you can know, the peripheral nerve plexus is actually derived from neural crest cell, and all of them are mandatory plexus present in the muscle layer of the gut tube, and they actually derive from neural crest cell. Especially the distal portion of the gut tube may not get mandatory plexus, such as sigmoid colon and rectum. So there is failure of migration of the neural crest cell to the sigmoid colon and rectum. So there will be some portion of the gut tube which is aganglionic, which will not have ganglions. So it is also called, the Hirschsprung disease is also called congenital aganglionic megacolon. Megacolon, why? Because as there is no mandatory plexus, there will be loss of peristalsis of the hindgut. So the hindgut will be unable to open up and will pass the food material through it. So there will be retention of the feces, and this fecal retention will ultimately lead to distension of the proximal normal bowel. Okay, so here we can see a barium enema. So this portion of the bowel, as you can see, this portion is actually very narrowed. So this patient most likely does not have any mandatory plexus, and that's why it didn't actually it didn't have any peristalsis, didn't have any movement, it didn't dilate. So the feces could not pass through here well, and that's why it accumulated, and the gash also formed. So this portion of the bowel which is dilated, hugely dilated portion, this is the normal portion of the bowel. So you have to cut out the abnormal portion to have the feces to go through the distal portion of the bowel easily. So that's all from me. Thanks for watching the video, and if you have anything unclear, please let me know. I'll try to make it clear. Thanks again.